Chronic obstructive pulmonary disease is an umbrella term, covers a lot of different diseases. We will look at two of them more closely today. So it's usually called COPD, but it stands for chronic, long-term, obstructive, something's blocking, pulmonary disease. The two most common diseases are chronic bronchitis and emphysema. These two diseases often coexist in a patient with overlapping symptoms, making it very difficult to differentiate between the two. The causes: prolonged or long-term cigarette smoking is the primary cause for both chronic bronchitis and emphysema. Other contributory factors include air pollution, exposure to irritating inhalants, smoke, wood smoke, allergies. There's a genetic predisposition to COPD, and also chronic infections. Chronic bronchitis is a condition of excessive mucus production. It causes a cough with expectoration, which is a productive cough, which means basically you are coughing up a whole bunch of phlegm and mucus all the time. Kind of gross to think about that, isn't it? So much phlegm. So you have to have this productive cough for at least 3 months of the year for more than 2 consecutive years before that you can be diagnosed with chronic bronchitis. So the pathophysiology is the bronchial walls become thickened, and we talked about this thickening during an asthma attack as well. But these bronchial walls are chronically thickened by infiltration of those inflammatory cells, those chemical mediators of inflammation. Additionally, mucus glands increase in size and production, and this brings about excessive mucus production, right? Now they're bigger and they're increasing more, you have way more mucus. And because the airway itself is narrower, because the bronchial walls are edematous or thickened, it's very difficult to cough the mucus up. And this obstruction is present on both inspiration, meaning inhalation, and expiration, exhalation. The signs or symptoms, that predominant feature, that number one thing you see, is this chronic cough with copious, and copious means a heck of a lot of sputum or mucus or phlegm. The patients tend to be overweight and be cyanotic, and cyanotic means look a little blue. And in fact, they're called type B. When you have chronic bronchitis, they call it type B, and they call them blue bloaters because they're cyanotic and they're bloated. They're overweight. They have a mild disordered breathing, that dyspnea. They also have frequent respiratory infections. So now let's look at emphysema. So emphysema is a condition where you lose the elasticity in the alveoli of the lungs. And we talked about that when we looked at lungs earlier. And those alveoli look like grapes. In the grapes, there's like a lot, if you can imagine like a whole bunch of grapes together, they all have a skin around them. That skin, that wall of the alveoli is like a trampoline. It's super springy. And that super springiness causes air to be exhaled. It pushes it out. Now, emphysema condition causes that springiness to be lost because the alveoli, instead of looking like 12 grapes, they look like 3 grapes. A lot of the walls are missing in these. Instead of being all tiny little clusters of grapes, they're big. What's a good word? Like an orange, right? There's like 3 oranges instead of 12 grapes. So the air, instead of being sprung out, gets trapped in these air spaces because the walls of the alveoli have broken down. Additionally, there's a loss of capillaries, which serve the alveoli, these grape clusters. And when you lose that sort of all those capillaries, which is where that nice gas exchange is happening, you decrease the exchange of carbon dioxide and oxygen. And the loss of this capillary bed also interferes with the pulmonary circulation, which in turn increases the workload of the right side of the heart. So the normal elasticity of the lungs is severely impaired. So the lungs are sort of flabby instead of springy, making them easy to fill, but not to empty. So the lungs never fully empty on expiration. And in advanced stages of emphysema, the lungs are in a position of near full inspiration at all times. So let's look at a picture of those. So here's like those 12 grapes I'm saying, right? You could see here, these are all the walls, and these walls help to push air out. These are the springy walls. So in emphysema, these walls are broken down. So you have many fewer walls, they're becoming more rigid. And so you don't have a good ability to exhale the air. So what does emphysema look like? So chronic bronchitis looked like wet, juicy coughs. Emphysema looks like this disordered breathing when they exert themselves. So someone that might walk up steps and they're like any kind of exertion causes like a gasping. They may have a minimal non-productive cough. They can also have cor pulmonale, which is an enlargement and then an eventual failure of the heart's right ventricle. And we'll talk about that. And pulmonary osteoarthropathy, which is a clubbing of the fingers from the distal phalange forward, and a barrel-shaped chest. The chest, is shaped like a barrel because the accessory muscles of respiration start to get involved to try to get that air out of the lungs. So the person tends to have a larger chest. So when we talked about emphysema being a type B blue bloaters, emphysema, they call it type A pink puffers. So they purse their lips when they exhale. In pursing, not so much like a kiss, but like when you kind of suck on a straw look. And it's also important to note, emphysema and chronic bronchitis can kind of be overlapping in patients. So signs of emphysema can also be seen in chronic bronchitis, and they can overlap, and it can be difficult to differentiate. So cor pulmonale, let's go over blood through the heart. All right, so we got the inferior superior vena cava that's dumping the deoxygenated blood in here into the right atria. So the right atria then sends the blood deoxygenated down here to the right ventricle. The right ventricle then ejects that deoxygenated blood here into the pulmonary artery, the only artery in our whole body that carries deoxygenated blood. And it pushes that blood, pulmonary lungs, to the lungs to pick up oxygen. So when it's pushing the blood into this pulmonary artery to go to the lungs, because they've lost that elasticity and they are stiffer. If you can imagine, if something was sort of elastic and you pushed against it, it would be easy. But the stiffer the thing became, it would be more difficult to push. So because the lungs are stiffer, it's harder for the ventricle to push that blood, deoxygenated blood, through the pulmonary artery. So what the heart will do is something called remodel. Now, remodeling your kitchen, yay. Remodeling of your heart, nay, bad. It will enlarge. The heart is a muscle, and like, if you're pumping weights, your muscle gets bigger, it's more forceful. That's good initially. So initially, when that heart enlarges, that right ventricle enlarges, it can go against or push against that excessive pressure that's in the lungs. But eventually the heart cannot keep up with that always pushing towards the lungs. And the blood will now start to back up. So initially the right ventricle will stretch or dilate, get bigger, and then the right side of the heart will begin to fail. And when that happens, blood flows backwards, and you could see in the patient, if it goes backwards, back towards the inferior vena cava, you'll have swelling in the ankles. If it goes to the superior vena cava, you will see a distended jugular vein in the patient. So not good, this right-sided heart failure. The other thing that you'll have is swelling at the distal phalanges here of the fingers. Why it's caused, it could be like a hormonally related problem. Another reason why they think it might be caused is the extremities are the last thing to get the blood, right? So if you've ever been outside in the cold and your toes are so cold, right? Your fingertips are so cold. It's the last thing that's getting the blood. So the body might actually be forming more capillaries to get more oxygen, more blood out there, since the body's having trouble getting that gas exchange happening. And so you see this growth at the fingertips, potentially from the body trying to make more capillaries to get blood there. But it's multifactorial. So it's not the only reason there's lists and lists of why they think it may happen. So what are some dental precautions with someone with emphysema? You want to keep that patient in a semi-supine position, follow stress reduction protocol. Supplemental oxygen. So we learned about COPD and oxygen being their main stimulus of breathing. So it's not recommended to give them oxygen, but here is why you see sometimes people with emphysema carrying around an oxygen tank behind them. You can give them oxygen, but it can't exceed 3 liters per minute. So normally people would be getting 4 to 6 liters per minute. You can't give them more than 3 liters per minute, because in the late stages, very late stages of COPD, the lowered arterial oxygen levels become the main stimulus to breathe. You start flooding them with oxygen when they're in the later stages. They may lose their ability or that stimulus to breathe. You want to avoid anything that depresses the central nervous system, like nitrous oxide, narcotics, pain pills, Vicodin, things like that, barbiturates, because this could also all depress the respiratory drive. We talked earlier about cold and air, dry air. Things that are very drying are also not great for us because we want to be hot, wet, right? That's what we are. And you also want to avoid recommending erythromycin in patients that are taking inhaled theophylline. All right, tuberculosis. It's an infectious, it's contagious, inflammatory, reportable disease. That means it's tracked by the government. That's chronic in nature and commonly affects the lungs. Extrapulmonary TB would be a type of TB that's outside the lungs, and it can happen and can occur. Extrapulmonary tuberculosis rates are higher in patients with HIV infection. TB is considered an AIDS-defining condition. So in the past, the last stage of HIV infection was called AIDS. So when you would be diagnosed with AIDS, your T cell, your immunity had been so suppressed. At that point, you would be given a certain amount of time that you would be left to live. Now, currently, it's there in the literature. They're starting to transition AIDS into becoming HIV stage 3. And it's no longer considered like you have a limited time left with the medications that are available. HIV infection is considered chronic. And even if you're at HIV 3, the old terminology would be AIDS, you will still be able to live a long, healthy life beyond what in the past they thought. So right now, in some of the literature, it's called AIDS, the last stage, but now we are transitioning to calling it HIV 3. And when you have HIV stage 3, you can actually get better and get back into HIV stage 2. So that's pretty exciting. Lots of different information, exciting new treatments and things happening that we'll be talking about later in the semester. So TB, Mycobacterium tuberculosis, is what causes it. It's a bacilli, and this bacilli is known as a tuberculous bacilli. It forms spores, which are very difficult to kill, and it can live for months in dried blood and mucus and dust particles if they're not exposed to light. So the most common mode is how TB is transmitted is inhalation of fresh droplets, which sounds like the absolute grossest thing. Blah. But I'm kind of used to it now because they've been talking about COVID, and that's basically someone coughs a whole bunch of mucus into the air, and you happen to just walk through their mucus cloud and inhale it. Well, TB is the same way. Indirect contact is also possible, but the most common one is you're inhaling someone else's saliva, basically, deep into your lungs. Use of an ultrasonic or other handpiece, air-water syringe creates aerosols which carry the bacilli. So transmission, whether the other person gets it, is the degree to which the diseased person produces infectious droplets, the amount and duration of the exposure, like are they coughing all over you and you are repeatedly inhaling their mucus cloud, and also how well is the other person that's inhaling the mucus cloud. So TB is divided into two things. It can be a latent, latent I think of as a sleepy infection, or it can be disease, which is active and can be transmitted. TB infection with no active disease cannot infect other people. Persons with TB infection who do not have active disease usually have a positive reaction to the Man-2 tuberculin skin test, usually done on your forearm. They'll have a negative chest x-ray and no clinical symptoms of tuberculosis. They have the tuberculous bacilli in their body. It's usually in their lungs. And although contained, these bacilli remain viable and capable of producing active disease at any time. TB disease does not develop in everyone who's infected. In 90% of the cases, the initial exposure results in asymptomatic infection, which remains for life, but no symptoms ever develop. So our macrophages engulf the organism, but don't kill them. They surround them in tiny hard capsules called tubercules. So our macrophages come to fight them, and they end up creating like I think about it like a Skittle, like you know how it's hard on the outside, but and unfortunately, instead of having a delicious rainbow on the inside like a Skittle, you have a bunch of tuberculosis on the inside. So these little Skittles or tubercules results in this latent or sleeping infection. Now, the sleeping infection can be woken up later, particularly if the immune system weakens or if you take certain medications. The latent infection is a persistent infection following a primary infection. You get the disease and it goes to sleep. So the causative agent, the tuberculosis, is inactive within certain cells. About 85% of all TB cases occur when the latent infection is reactivated or woken up. TB disease is becoming a prevalent problem for patients infected with HIV because of the immunosuppression. So TB and HIV patients must be treated more aggressively, and for longer periods of time. So the incubation is 4 to 12 weeks. Signs and symptoms: fever, weight loss, anorexia, not the disease. This means loss of appetite, fatigue, night sweats, persistent cough for longer than 3 weeks. The diagnosis is a positive chest radiograph. The disease, when it's active, shows formation of cavities in the lung tissue, and a tuberculin skin test known as the MAN2 test. So this is our most reliable and useful test. An intradermal injection of purified protein, which is a derivative of tuberculin. So 8 to 10 millimeters is a positive reaction. 5 millimeters or greater is considered a positive reaction in a person infected with HIV. Tests are usually read 48 to 72 hours later, and periodic testing is recommended for all healthcare workers. So here they are measuring it in the forearm. Treatment. It's curable if diagnosed early and treated quickly. It requires multiple drug therapies. We'll talk more about them in pharmacology. So I list here 3, but it's up to 5 separate drugs given for a minimum of 6 months. And because the bacilli themselves develop drug resistance very quickly, and improper treatment if the person stops taking the drugs may foster the development of drug-resistant mycobacteria. So an infection, a positive MAN2, you have the swelling on your arm, but you have a negative chest x-ray, you will only take the drug INH alone. So the BCG vaccine, it does provide partial immunity in most people. It's really not used much in the United States. It's more often in countries where the prevalence of tuberculosis is high. So dental management. Active disease. They may be treated after the patient has about 2 to 3 weeks of the multi-drugs, it's called chemotherapy, if non-infectious. And you also want to consult with the physician to determine the infectious state. Treat as usual. They've had TB in the past, consult with the physician, rule out reactivation, treat as usual. Recent conversion to a positive skin test. Consult with physician to rule out active disease, treat as usual. Signs and symptoms of TB, refer to physician, postpone treatment.